Hello, everybody. Today we are going to talk about driving pressure. So, current guidelines for the lung protective ventilation in patients with acute respiratory distress syndrome suggest the use of low tidal volume set according to the ideal body weight of the patient and higher level of the PEEP to limit the ventilation-induced lung injury. However, recent studies have shown that ARDS patients who are ventilated according to this guideline may still be exposed to forces that can induce and aggravate lung injury. So, what does driving pressure represent? So, after description of the baby lung concept, which revealed a physiologically small lung in patients with ARDS, several studies in 1990 tested that the hypothesis that limiting the tidal volume and airway pressure during mechanical ventilation might improve the outcome of this patient. In pioneering single-center study, Amato et al. Were the first to show reduction in the mortality in this setting using the strategy based on maintaining low inspiratory driving pressure along with low tidal volume and high PPs. Shortly after a large multi-center ARDS net trial showed the decrease in mortality by nearly 25% in more than 800 patients with ARDS using 6 instead of 12 ml per kg of idle body weight, confirming that the tidal volume limitation is fundamental strategy to improve survival of patients with ARDS. However, some controversy was generated about the best way to titrate tidal volume, ideal body weight, body surface area, lung size, airway pressure. Going further back, the rationale of limiting tidal volume emerged from the description of the concept of baby lung, which tells us that in ARDS, we are facing physiologically small lung, not rigid lung as previously thought. In Gattoni et al. Original study, while oxygenation and shunt are correlated with non-aerated tissue, static lung compliance was strongly correlated with residual aerated lung volume and the volume of baby lung. So driving pressure is the difference between airway pressure at the end of inspiration, that is P flat and P. So in turn, static compliance of the respiratory system is the quotient between the tidal volume and driving pressure. Ergo, by simple arithmetic, driving pressure is the quotient between the tidal volume and compliance of the pressure. Compliance of the patients. So the driving pressure is the P flat minus P. And the compliance is tidal volume upon driving pressure. So the driving pressure is tidal volume upon the lung compliance. Thus, the driving pressure represents the tidal volume corrected for the patient's lung compliance, and using the driving pressure as safety limit may be better way to adjust the tidal volume in order to decrease the cyclic and dynamic strain during mechanical ventilation. Transpulmonary driving pressure, that is the difference between airway plateau minus peak pressure and the esophageal plateau minus end expiratory esophageal pressure. When taking into account the chest wall elastance could better reflect the lung stress and be safest way to titrate mechanical ventilation. In this context, the Chimolo et al. Conducted retrospective analysis of 150 deeply sedated paralyzed patients with ARDS enrolled in previous studies, in which PIP trial of 5 and 15 was performed at constant tidal volume and respiratory rate. At both peak level, the higher airway driving pressure group had significantly high lung stress, the respiratory system, and lung elastance compared to the lower airway driving pressure group. More importantly, the airway driving pressure was significantly related to the lung stress and the driving pressure higher than 15 centimeter of the water and transpulmonary driving pressure higher than 11 centimeter of water, both measured at peak of 15, was associated with a dangerous level of stress. Difference between transpulmonary driving pressure and airway driving pressure are mainly due to increasing chest wall elastance. Airway driving pressure was vary from the minimum differences to the large overestimation of the transpulmonary driving pressure. However, in patients without spontaneous ventilatory activity, transpulmonary driving pressure will always be lower than the airway driving pressure. In summary, the driving pressure during mechanical ventilation is directly related to the stress forces in the lung. Sizing where tidal volume in proportion to the size of the baby lung by targeting driving pressure rather than to ideal body weight might better protect the lungs in patients with more severe lung injury and low end expiratory lung volume. Now, evidence relating to the driving pressure to pathophysiologic alteration. One of the most problem when setting ventilation in ARDS patient is right ventricle overload, which related to the lung derecruitment and over distension, and has also been reported to be independently associated with poor prognosis. In the prospective observational study in 226 patients with moderate to severe ARDS ventilated with plateau pressure limited to 30 and assessed with transesophageal echocardiography, cor pulmonale was detected in 49 patients and higher driving pressure were independent factor associated with cor pulmonale. More recently, the driving pressure of more than 18 and PaO to FiO2 ratio of less than 150 and PCO2 of more than 48 have been reported to promote RV failure in patients with ARDS caused by pneumonia. There are also reports that describe the association with driving pressure with diaphragmatic function. In 107 patients on mechanical ventilation, Bolliger et al. Found association between high driving pressure and decreased thickness and contractile activity measured by ultrasound. Now, regarding clinical use of driving pressure, as discussed, high driving pressure is strongly associated with high mortality. The safe limit of the driving pressure have not been identified and suggested cutoff vary from 14 to 8. In clinical study comparing the higher versus low tidal volume ventilation in patients with ARDS, conventional non-protective strategy resulted in driving pressure greater than 20, while protective ones were usually below 15 to 16. In contrast, in studies comparing high versus low peak, in which all group limit tidal volume, mean driving pressure were well below 50. In the absence of prospective studies using driving pressure as a goal when setting the ventilator, we suggest that driving pressure should be used as complement to, not as substitute for VT. Accordingly, we should maintain the tidal volume, a target of 6 to 8 ml per kg of ideal body weight, and then control its safety according to driving pressure. Although there is insufficient evidence to suggest specific cutoff value for driving pressure, we propose 15 centimeter of water, not as target but as safety. In contrast, in patients with moderate to severe ARDS and other restrictive disease, a driving pressure above 10 will be common and it may reflect either diminished compliance and inappropriate tidal volume upon PEEP set. Driving pressure may be a valuable tool to set PEEP. Independently of the strategy used to titrate PEEP, changes in the PEEP level should consider the impact on driving pressure besides other variables such as gas exchange and the hemodynamics. Decreasing driving pressure after increasing PEEP will necessarily reflect recruitment and decrease in the cyclic strain. On the contrary, increase in driving pressure will increase the non-reportable lung, in which over-distension prevents the over-recruitment. If after optimizing PEEP, driving pressure remains 15, we suggest further decreasing tidal volume below 6 ml per kg of ideal body weight. In addition, esophageal catheter may be considered to measure the transpulmonary driving pressure. So in controlled mechanical ventilation, where we are initially setting the tidal volume of 6 to 8 ml per kg of body weight. So check the ventilator parameters and measure the driving pressure. If driving pressure is less than 15, keep the ventilator parameter as it is. If it is more than 15, then decrease the compliance. If it is a ARDS lung, then limit the tidal volume to 6 ml per kg. Then try recruitment maneuver and decrement PEEP titration to best compliance. Apply prone NM blocking agent if PF ratio is less than 15. If driving pressure is more than 15, consider further decreasing tidal volume below 6 ml per kg of body, ideal body. If uh, if other restrictive disease than ARDS, then limit the tidal volume to 5 to 6 ml per kg of idle body weight, and also optimize the PEEP to decrease driving pressure below 50. Now, evidences relating to the driving pressure. The association between driving pressure and outcome was first described in 2002. In prospective observational cohort of 235 patients with ARDS, Estensoro et al. Showed that driving pressure during first week consistently discriminated between survivor and non-survivor, along with other variables such as PF ratio and SOFA. More than a decade later, the best evidence comes from the Amato et al. With meta-analysis of the 9 prospective trials involving more than 3,500 patients showed that driving pressure was the physical variable that best correlates with survival in patients with ARDS. More importantly, this association existed even though all ventilatory settings were lung protective. After the report by Amato, several authors confirmed the association of driving pressure with survival. In 56 ARDS patients from ICMEN trial, which tested the use of esophageal manometry in patients with ARDS. So, Bedroff, Kisse et al. Found that utilizing PEEP titration to target positive transpulmonary pressure result in both improved elastance and driving pressure. Then the author also suggests the ventilation strategy leading to the decreased driving pressure and elastance could be associated with improved survival. The ultra protection ventilation used with extracorporeal lung support may help protect the lung by decreasing tidal volume along the driving pressure. In recent meta-analysis from 9 studies, including more than 500 patients receiving ECMO for refractory hypoxemia, Sarpan et al. Shows the driving pressure during first 3 days in ECMO had independently associated with in-hospital mortality. Although ECMO support allows decreasing tidal volume to 4 ml per kg of idle body weight, driving pressure is nearly 4. Non-survivors still have higher driving pressure during ECMO. In largest observational study, nearly 2,400 patients with ARDS, driving pressure of more than 14 was associated with increased risk of hospital mortality in patients with moderate to severe ARDS. The interesting data from this study indicate that there is still significant potential for improvement by correcting modifiable factors associated with increased mortality, including driving pressure. So this is the article published in NEJM, which showed the driving pressure was the ventilation variable that was best stratified risk, and the decrease in driving pressure to the changes in the ventilatory setting was strongly associated with increased survival. Thank you, guys.